Greetings, everybody, and thank you so much for the invitation to be part of this Hui. I'm very delighted to be part of it. Can I just check that my microphone is working okay? Okay, thank you. I'd like to start by acknowledging the Bidjigal and Gadigal people of the Eora Nations, who are the traditional custodians of the lands from which I'm presenting today, and acknowledge that this is unceded Aboriginal land, and it always was and always will be Aboriginal land. My own background prior to coming to live in Sydney is that I have actually a strong connection to the south coast of Western Australia and Noongar country, and I also pay respect to the elders of that place who have um, assisted me and mentored me in my approaches to research and hopefully moving beyond colonizing approaches to research. I'm very happy to be part of this group and excited to see the work that's underway from the Law Commission and supported through the New Zealand Dementia Foundation. And what I'm hoping to do today is just to provide a bit of our experiences in Australia in looking at supported decision making, particularly in the context of dementia, and to update you, I guess, on where that research is at, and hopefully it's helpful, and look forward to sharing and being part of the conversation. So I'm just going to share some slides, and I am trying to cover a little bit about I guess, the human rights basis to this work, as well as what we see in practice, and the research that I'll talk about has been very much centered on the practical experiences of people living with dementia, those caring for them, and professionals who are working with these people as well. So I will have to move through things quite quickly, but the slides should be available, and I'm very happy to be contacted after the session as well. So in terms of what I'm hoping to cover, I'll be starting with some of the human rights basis of supported decision making, and then looking at how this actually presents in practice and the sort of experiences that we hear about from people living with dementia, some of the policy and law reform issues that we've encountered in Australia, and which are quite present at the moment with some new legislation that's coming before Parliament soon, and perhaps some suggestions for where we might look in terms of future directions. So in terms of the human rights basis to supported decision making, I think this is something that I'll come back to across the talk that I'm giving today. Is it's really important to understand where this work has come from, and that later, I guess, informs some of the conceptual elements around particularly the concept of will and preference, and then how we think about that in the context of a condition like dementia, and how we then can support the expression of will and preference. This work has been grounded in the disability advocacy movement, and one of the really important contributions that's been made through this sector, I think, has been helping to shift our understandings of disability from a medical approach to disability that sees the source and cause of disability as primarily intrinsic to the person and around their impairment, to broaden that understanding and to think about this as really an interaction between both the person's impairment, which may develop and change over time, but also the presence or absence of societal accommodations that can assist a person in maintaining active inclusion in society. So the example shown in the picture here, of course, is a person with a visible and physical impairment and the need for mobility assistance to enable his active inclusion in society, and the lack of a wheelchair ramp, or a simple and reasonable accommodation, is what is, in this case, really the source of the disability or the ineffective inclusion. And so the challenge when we think about conditions that lead to less visible or internal sources of disability is to think about, well, what are the ramps and what are the accommodations that can be useful, effective, and feasible to be able to apply, so that people living with dementia can enjoy that same active inclusion in society. When we define supported decision making, we need to be casting a very broad net, because the types of decisions are very diverse. The types of disabilities are very diverse, and the context in which all of this unfolds is also another source of diversity as well. The United Nations defines supported decision making as the process whereby a person with a disability is enabled to make and communicate decisions with respect to personal or legal matters. And when we think about a practice, or conceptualizing a practice for what this looks like, some of the key ideas that have been put forward and advanced in this work are around the idea that this is a voluntary process, that it's about supporting a person in their own decision making as far as possible, and I'll unpack that a little bit more later. And then we start to think about the more functional aspects of what that support might do. So assisting a person to understand, assisting a person to weigh up options, and or to communicate options. And for those of you who are working in the area of decision-making capacity, you'll see a lot of parallels there, I guess, to some of the conventional ways that we think about a functional approach to decision-making capacity. And that this is actually about providing assistance to help a person demonstrate that capacity. But more broadly than that, it's also about developing a person's decision-making ability. So that's a recognition that all of us develop in our decision-making abilities through the act of making decisions and participating and in authoring our own lives. And some people, because of the context of their disability, have not had access to that in their background. So that's something that I think is important, along with attempting to create enabling contexts. So, for example, people who have lived in institutional settings for a long period of time may have been removed from those enabling contexts, such as the trusting and familiar family relationships or social relationships in which you would normally access support for decision making. So it's, I guess, broader than just identifying functional impairment in a person's cognition and then thinking about how to support that. It's actually a more broader process. And that leads me to the last point there, where there's a bit of a differentiation between this term supported decision making and support for decision making. That's really a recognition that this whole package of ideas and principles, if you like, requires more than just action at the local level with a person. It's also talking to the policy and legal landscape, all of the things that actually contribute to a person's will and preference being respected, and the safeguards around that. So some would argue that we can't really have supported decision making while laws are inconsistent with that, and others focus on, well, what can we do right now, and talk about that as the support for decision making, or the practical things that can be done. When we locate support for decision making, often we're thinking along a spectrum, and that comes through, I think, in the empirical work as well, where we actually go out to the community and work with people and hear their stories, and they're really talking about different spectrums. So that might be spectrums of levels of impairment, it might be life courses, it might be working through more simple or more complex aspects of a certain decision. And what we might be more familiar with is I guess, the idea of a person to some extent making independent decisions, acting as an agent in terms of making decisions about their own life. And then at some level, there might be mechanisms or frameworks in place to authorize a person to make a substitute decision on behalf of somebody else. And in this space in between, there's also this idea of supported decision making, where the figures there are suggesting that the people around that person are present in the process, but it is still the person's voice that is driving the decision making. And I think there's actually quite a bit to unpack here, because you can see, I would imagine, some Western ideas around individuals and where they actually exist relative to others. I'm not going to try to cover that in great detail, but I think it's important to acknowledge that different cultural reference points would actually perhaps challenge the idea that there is any sort of individual or independent type of decision making. The one other thing I just wanted to note on this is that, because historically the work in supported decision making, a lot of the scholarship, a lot of the innovations have really come from the disability sector, where a lot of that work has been located has been with people with lifelong disabilities, where maybe they're starting from a point of substitute decision making and attempting to provide support in I guess, with the aim of enabling a person to exercise more autonomy across the course of their adult life. And that might be particularly around a person leaving the care of parents and moving to live independently at some point in their life. And when we're thinking about dementia, the spectrum perhaps operates in a different way, and people who have made decisions somewhat independently or with support across much of their life, who have accumulated social and family resources, financial resources, are now in a position where perhaps for the first time in their life, they're struggling to make some of these decisions and are either requiring support or in some cases substitute decision making. This work has been grounded in some key international treaties, in particular the Convention on the Rights of Persons with Disability. And I'm presenting this, I guess, just as an acknowledgement of the importance of this document, as a way of acknowledging that fundamental human rights exist for all people, and that people living with disabilities have faced particular barriers in terms of enjoying those rights on the same basis as others. It's also important that the articles of this convention are not read in isolation, but in this case, Article 12 is the one that directly refers to supported decision making, refers to legal capacity and the right to legal capacity. Interestingly, the term supported decision making doesn't appear in the convention, but it is the conceptual basis for what we're talking about. So that convention says that people with disabilities are recognised as persons before the law, that they have legal capacity on an equal basis with others, have a right to access support, and that there must be safeguards to prevent abuse. Those wordings are actually paraphrased and contained for the purpose of the slide, but they're the key clauses that we're referring to here. The main messages that I want to bring out around this convention is that it doesn't entail new rights, but does provide an explicit new framework for supporting law reform and advocacy around people living with disability. It entails a decoupling of mental and legal capacity, and that is quite an important conceptual step in what we're talking about here. So the idea that a person can still enjoy legal capacity even as their mental capacity may be changing and may be impaired. There's a positive wording of a right to access or receive support, which is a new component here. So in the past, scholarship around autonomy has often focused on the right to be free from interference from external influences, and that might be institutions, or it might be some other external factor. But in this case, we're talking also about a right and a positive right to actually have access to the support that one needs in expressing will and preference and having that respected. And that these articles should not be read independently. So they all exist alongside the other rights and the other articles in this convention. Australia is a signatory to this convention and to the optional protocol, which means that Australia regularly is assessed by the committee on the rights of persons with disability and has to respond to those reports. And one of the first responses in Australia back in 2014 was the Australian Law Reform Commission's National Decision-Making Principles, which echoed the requirements of the Convention around supported decision-making through these 4 principles that have been seen as the blueprint for future legislation and law reform, particularly at a Commonwealth level. Although, as I'll come to a little bit later, we have a complex federated system where much of the law that governs the everyday lives of people living with disability, particularly in health and financial matters, exists at a state and territory level. So that does create some complexities.
Okay.
But in any case, it has been quite influential in terms of prompting law reform at a Commonwealth level, and also has stimulated law reform reports at state and territory level. So we've had some key reports from Queensland, Wales and Victoria. That has also resulted in some state-based legislation in Victoria, which does now enable the appointment of a supportive attorney for financial matters and a supportive guardian for health and lifestyle matters in Victoria. That does have some limitations around it. And it will also be interesting to see what happens in other states. There's a working group who are currently responding to a quite overdue Law Reform Commission report from New South Wales, which was handed down in 2018. I think the pandemic had some impact on the government not responding to that, but we hear that is actually underway now. So hopefully there'll be movement there in future. Another important development that we've seen in Australia recently over the past 4 or 5 years has been 2 quite key royal commissions that have directly addressed this topic. The first one was the Aged Care Quality and Safety Royal Commission, which made some high-level comments acknowledging the importance of supported decision-making, but no specific recommendations. It did acknowledge previous calls from the Australian Law Reform Commission to embed the national decision-making principles in a new Aged Care Act, which was required to be a rights-based act. But when they came to frame the recommendations around that act, it was mostly in terms of economic aspects, such as access to aged care, and there was some recognition of restrictive practices. And the fact that we had conflicting recommendations from 2 commissioners also played quite a key role there. The reflection looking back on this is that the absence of an explicit convention on the rights of older persons, in this case, perhaps meant that there was a difficulty in really addressing these points. And when a later Royal Commission handed in its report in 2022, the Disability Services Royal Commission, it was able to instead draw directly on a convention on the rights of persons with disabilities. And so supported decision-making was central not only to the recommendations, but to the whole process of undertaking this Royal Commission. It also had access to a longer history of research and practice in supported decision-making across the disability sector. And it was acknowledged quite clearly that I guess, dementia and aged care sectors in Australia were earlier on their journey in terms of grappling with supported decision-making. It's something that has been more a normative practice in the disability sector. However, dementia and aged care settings were included in the terms of reference, and the result of, I think, both of these commissions has been quite strong wording that's coming from the Department of Health and Aged Care now about what the focus of the new Aged Care Act will be, and that it will include rules on supported decision-making to ensure older people have choice and control. So it's a bit of watch this space there. There has been an exposure draft for that new Aged Care Act, but we're still waiting to see the form that it takes when it comes before Parliament sometime later this year. I was very fortunate to be invited to join a group who were commissioned to do some research on supported decision making as part of that Disability Royal Commission. And particularly, we were asked to write a report that would inform a national framework for supported decision making. So that's something that extends beyond the law itself. The law is obviously an important part of it, but it actually starts to ask us to think about how does this work across different sectors, across different jurisdictions, and at the practical level, what is the evidence base around how to do supported decision making and how to implement it at a program level. So this framework did address more than the Australian Law Reform Commission's report did. It echoed those first four principles, but it also identified some aspects from our empirical research, which we felt was important in terms of developing this practice beyond just the legal reform. And that included moving beyond the binary of saying, is this supported or substitute decision making? And instead adopting a principled approach that looks at keeping an individual's stated or perceived will and preference at the centre of decision making. And that ties in with the UN's requirements that where a person can't express their will and preference, we adopt a best interpretation of will and preference using previous expressions or interpretations of a person's current expression of will and preference. It required an explicit recognition of the fact that there are risks in these decisions, and that service providers and a range of different actors in this process do need to be considering ideas around dignity of risk. And importantly, I think these principles really play out in the context of resourcing and equity issues. So those experiencing disadvantage, whether that be financial, cultural, whatever the source of a person's disadvantage or marginalisation, need to have access to support, and that should be given priority, as well as co-leadership of people living with cognitive disabilities. I'm just wanting to unpack a little bit about these comments about a binary and principled approach, because what we found, sorry about that, what we found in this work is that there was different understandings of what is meant by the term supported decision making. And for many people, I think it has been something that they have quite understandably started with what they know well, which is that there is a framework for substitute decision making, and then thinking about how do we add something like supported decision making. And so thinking that from a binary point of view, the person's making a decision, we can provide some extra support to actively involve them as far as possible. But at that point where that is not possible, we default to the norm, so the substitute decision-making approach. And in many states and territories in Australia, that is still based on a best interest judgment, where someone else is making a judgment about what is best for that person, which is not consistent with what's required under the CRPD. On the other hand, what we're arguing for in this report here is what we have called a principled approach, which starts by saying it's not so important to say whether something is substitute or supported, but it's important to centre the person's will and preference across this whole process. And the importance of that is to think about how these principles would apply for somebody who has profound disability, or for someone who has never had the opportunity to develop in the sense of being able to express will and preferences in the past. And so there's no reference to past expressions of will and preference. So like on the left side, the person is supported there to be actively involved as far as possible. The decision making is based on their stated will and preference. And if that cannot be ascertained, the supporters are required to make a best interpretation of the person's will and preference. So I guess it's a small but important shift in thinking, which I think will be important, and it does actually then direct us to what is this concept of will and preference, and how do we put that into practice. Going back to some of the language that has been drawn on here, when we think about the use of the term will, this is often associated with a person's deeply held, reasonably stable, and reasonably coherent personal values. And I'm referring here to both Carney, Terry Carney, and Schmuckler in their outlining of how they're conceptualizing will and preference. So we can think of a person's will as reflecting higher order processes of deliberation and reasoning that relate in some way to their own value system and are generally coherent with their other beliefs, intentions, and general temperament. On the other hand, a preference might be a more momentary desire, inclination, or preference, even when strongly expressed. And the importance of unpacking the different drivers of decision-making here, I think, is useful in the sense that we can perhaps all recognize these things playing out in our own lives. And the psychological research around decision-making has been quite has reached quite a consensus that there is multiple ways in which decisions can be made, and dual processes of decision making, some of which are more deliberative and some of which are more driven by emotion processes, impulses, and are less accessible to that deliberative process. The importance of this is that if we're trying to develop a disability neutral approach to decision making, requiring that people demonstrate in all cases this process of deliberative reasoning within a conventional capacity assessment framework actually excludes some of that decision-making process. And so what this is saying is that we would consider both a person's will and their preference, and recognizing that while these things may run together, and you know, the term will and preference can roll off the tongue in that sort of way, we need to also consider what might happen when a person's longer term will is conflicting with their more momentary preference. And that you might recognize, you know, from some of the experience of conditions that occur, such as in certain stages of dementia, that those things can run counter to each other. And actually the interpretation of will and preference now would be directed towards understanding and unpacking all of that with reference to a person's life story and how they've made decisions across their life, but also recognizing that they may be changed in some way now and that those preferences still hold some weight. So the CRPD calls for a best interpretation of wills and preference when the person is not able to be supported to express that themselves. I'm turning for the last part of the talk just to some of the practice-based work that we've been undertaking over the past years, and just trying to, I guess, put this in the context of what does this look like on the ground, and just to orient this, it's around some of these key practice components of how do we identify supporters and what are the decision points, how do we resource this, what do supporters do, and what does the decision maker do, and who is seen as owning the decision. When we're talking about this practice, I think the one idea that unites all of this is that the supporter is acting as far as possible to assist the person, but always keeping their will and preference at the center of the process. Some of the quotes that I'll be showing now have been drawn from interviews with people living with dementia and care partners, and also professionals who are providing services for these people as well. So an important theme across this work is this relational experience of dementia, that it's something that impacts on not just the individual, but, as this person says, at least the individual and their carer, or to take it further, the family, friends, and associates. All of those people are somehow affected. And that thinking about this in that relational way directs us towards the social impact of attitudes towards dementia, and perhaps also more broadly ageism as well. So this person, Josie, in this case, is talking about having always been confident and sure of myself, but I'm not anymore. It's just not there anymore, probably because of other people's reactions. And that's in the context of acknowledging, some of the experiences that she had among her close circle of friends after receiving that diagnosis of dementia. So being talked across or not being included in social outings that she used to be involved in. The significance of maintaining involvement in decision making was referred to in terms of people's roles and identity, and the important contribution of people's identity across the course of living with a condition like dementia, and how it impacted on that. So Carmen here, a partner of a person living with dementia, talked about assisting her husband in staying involved in making financial decisions and managing the finances, because it was very important for him, and he liked to be the husband and the protector. So being able to maintain some aspects of a person's role and identity, and having support in being able to do that, was seen as very meaningful for people living with dementia and those around them. As we moved into this work, and some of these interviews became follow-up interviews, so we actually worked across a number of sessions with people, it became clear that we were actually seeing a lot more than just the unfolding of a person's medical condition that was leading to a decision-making impairment, but it was actually really a complex web of different factors that were all impacting on whether a person was able to be effectively supported on certain decisions, or whether we were seeing more of a substitute decision-making approach. And so I'm not able to go through all of these factors, but the reference there is available, and that is somewhere where you can, I guess, access those different factors. And what I'm referring to there is that this is occurring in a more complex context. People also shared with us a number of strategies that they were using every day to maintain involvement in decision making, or to support their loved ones in maintaining that involvement. And we're using here language that they have identified as different types of or clusters of difficulties that they were experiencing, and the sort of strategies that they used in response to that. So that might be repeating information in different ways, or taking a multi-sensory approach to supporting a person who has a memory difficulty, reducing the complexity of decision making for someone who has difficulty understanding or weighing up multiple options, thinking about how to safeguard a decision making process if somebody is vulnerable to suggestion and there were perhaps concerns about mistreatment or abuse, as well as having transparent communication across both the care partner networks and also professional service providers. For people who maybe were able to understand a decision but experienced challenges in terms of managing their behaviour, or that executive function around what to do or what not to do when, that people were talking about negotiating and attempting to manage these risks without managing the risk completely out of that person's life. And for people who were experiencing difficulty in communicating choices, assistive technologies, alternative media such as visual formats, photographs and cards were some of the tools that they were using. And they also talked about strategies for addressing these social and contextual barriers, such as challenging social isolation through support groups, negotiating with service providers if there was a lack of suitable options to tailor services, self-advocacy, which entails a high emotional burden for both individuals with dementia and care partners, but having to actually use that to challenge the attitudes of some service providers, and managing sometimes complex situations within their own family, such as opposing views about whether a person could or couldn't make decisions. So in looking at the perspectives of professionals, I'll need to cover this quite quickly, but they talked about needing to establish a basis for decision making, and that was beyond just establishing whether a person had the capacity for a decision, but actually thinking about, in this case, what should we be doing here? What are the important decisions? And noting some of them reflecting on their own practice, that sometimes they were, I guess, tending towards decisions that were important to the health system, rather than starting with what's important to the person and fitting the decision-making process and the support around that. They, particularly allied health professionals, were quite competent and very much able to describe in detail the sorts of supportive strategies that they were using with people living with dementia, such as scaffolding their approaches to conversation and questioning, and also using different communicative domains, and advocating that this be used more broadly across services. However, it was also challenging for these professionals as well. So thinking about their own sense of their professional boundary, and that the idea of being drawn into some sort of supported decision-making process could actually influence a person in some way, or plant an idea in somebody's head. So that was quite scary for some people. And we also, across the different professionals we interviewed, which ranged from medical, allied health, nursing, through to legal professionals and advocates, we arrived at this idea of there being a bit of a spectrum in practice, and that different professional views on what is the what is the scope of a particular profession will actually become quite important when we try to implement supported decision making. So, for example, some particularly at the legal end of the spectrum, we were seeing people who talk very much about, I can take instructions from this client while they have capacity, but I don't allow any influence from anyone else. And that was contrasted with a more relational stance, which looked at working with a more complex network of people, and without wanting to create any generalizations here, I think that spectrum is important to consider, and how these different professions will interact with each other when supported decision making is at play. This work has led to a range of resources, which I will invite you to access. They're through the Cognitive Decline Partnership Centre website, and they include videos with people being interviewed about their experiences, resources for aged care providers and the community, as well as a series of webinars. And I'd also like to acknowledge that there's been some work over a longer period of time from the La Trobe Support for Decision Making Framework Group, who have developed this work in the context of lifelong disability, but provide some really well-developed practice tools. And also from ADA Law in Queensland, and the resources from the Office of the Public Advocate in Victoria. And just in concluding, I think in terms of the policy and law reform issues that we are facing right now, it will be really important to maintain a strong stance around a rights-based approach, and thinking about not only the principles of how we implement this at law, but then when it's implemented in practice, thinking about dignity, diversity, and equity. So, the big unanswered questions in perhaps what I've covered today are around culture and different formulations of individuals in relation to others, the resourcing of how supported decision-making occurs, and the importance of avoiding binaries between supported and substitute decisions, so keeping will and preference central. what we're facing in Australia right now is the potential for an incoming Commonwealth law for supported decision-making, which will conflict with state and territory laws that require best interest substitute decision-making. So hopefully that's going to lead to further law reform to bring those into a more consistent place. But we're also going to see different levels of regulation. So tribunals that used to occur at a state and territory level, some of that may end up going to a Commonwealth level, and it challenges that idea of decisions being made close to home, with local knowledge and local expertise. So that's going to be a challenge, as well as how to regulate this practice. And in terms of future directions, just a quick reference to some of the work that our group are doing around life story work. We are considering this as part of a current clinical trial as potentially a way of practically supporting people in some of their future decision-making about advanced care planning. And that's through what we understand of the role of life story work in terms of its role of building relationships and reminiscence, perhaps acting as a scaffold for current and future decision-making by starting where a person is expert and then providing a platform for supporting decisions about where they may be less expert, and as a form of self-advocacy. So we're implementing this trial at the moment with home care clients, and we've just expanded to people with progressive neurological conditions and those living with HIV, as well as older adults experiencing frailty. There's a QR code if you're interested in finding out more about that work, and always happy to talk further about that. And thank you very much for your time.